Welcome to this concise video log on vaccine recommendations for aging patients with HIV infection. This program is provided by Clinical Care Options and is supported by independent educational grants from Gilead Sciences, Merck Sharp and Dome Corp, and ViiV Healthcare. This vlog was recorded by Dr. Howard Grossman. Before we begin, please note his disclosures on this slide. This vlog is part of a comprehensive educational program on caring for aging patients with HIV. You can gain CME, CE, or CPE credit for viewing these vlogs and download the slides by visiting our website, clinicaloptions.com.
Hello, I'm Dr. Howard Grossman, the Medical Director of Midway Specialty Care in Fort Lauderdale and a clinical affiliate attending physician at Florida Atlantic University. I just saw a patient who represents someone we frequently see in practice, and I'm going to go through some of the details of this patient. Harry P. is a 63-year-old African-American man who's been living with HIV since 1996. He's currently on dolutegravir plus emtricitabine and tenofovir alafenamide. He has some comorbidities. He has controlled hypertension and hyperlipidemia that's also controlled. His current CD4 count is 382. His viral load is undetectable. His BMI, as with many of our patients, is 35. He's obese. His blood counts are normal, chemistries. His negative for active hepatitis B and hepatitis C, and his HLA-B5701 also negative. Harry comes in every 6 months, and at his visit today, he told me that he'd heard he should get the shingles vaccine. But he'd also heard that he shouldn't get it because he's HIV positive. He wanted to know what to do. We talked about vaccines in general, and Harry told me that he does not remember his last tetanus shot. Maybe it was sometime when he was a teenager. He thinks he was vaccinated for some kind of hepatitis, and he's really unaware of any other vaccines. Vaccine coverage in the United States is really an issue, big issue, and many people are deficient in vaccinations. So this is a very important topic, and especially for our patients who are HIV positive. You can see in this slide that we have almost about 50% of people who are at high risk for influenza get vaccinated. But people who don't consider themselves at high risk have a even lower vaccination rate. We are pretty good at tetanus toxoid, at least given once in a person's life. But this slide really doesn't address the idea of boosters. And we see here for herpes zoster vaccine, as we'll see later on, that the numbers have been increasing over the last 10 years, but are still at a relatively low level. There are ethnic and racial disparities in vaccination rates that are even more severe. The latest data compiled from 2017 showed that compared to 2016, these disparities have continued for especially Hispanic and non-Hispanic Black patients. But there's lower coverage for both of those groups as well as for adults of Asian descent when compared with Caucasians. Relative to 2016, some of these vaccination differences widened, in fact. So for tetanus, for Tdap, these rates were even worse in people of color. And for herpes zoster, there were wider differences as well. Influenza vaccine numbers increased in 2019 and 2020 among all ethnicities and age groups, but still remain lower for Hispanic and Black populations. Here you can see two graphs, one showing influenza vaccine coverage by age, and more older adults are vaccinated, nearly 70% in 2019 to 2020. Of course, remember, we were encouraging people very strongly because we were already seeing that COVID-19 was out there. In addition, you can see that people who are younger have a very low vaccination rate, less than 50% in most cases. By race and ethnicity as well, you can see that for white non-Hispanic populations, the rate is about 50%, but for other populations, the rates are even lower. Here you can see shingles vaccine, and despite widespread efforts at publicizing the need for it, you can see that by age, in the 60 to 69-year-old age group, rates are still below 30%. In people 70 and over, they're a little bit better, but still we're talking about less than 40% of patients who really should be getting vaccinated have been vaccinated. By race and ethnicity, you can see that there's even wider disparities. Certainly non-Hispanic whites, we're talking 38.6% of people over 60 years of age. But among Hispanic and non-Hispanic Black patients, the rates are under 20%. Part of this is prioritization. There are lots of things we have to do as providers, and vaccines rank as very low priority here during Medicare wellness visits. So this was a survey of primary care physicians and nurse practitioners who ranked the 10 topics by priorities that they had for Medicare annual wellness visits, and vaccines are near the bottom. You can see that. Other things rank much higher. If we don't prioritize the discussion, we're not going to cover it. There are some barriers that are perceived. This was part of this survey, and these providers answered the question, how frequently do each of the following fears, misconceptions, or barriers prevent your Medicare patients from getting their recommended vaccines? And you can see here the high numbers for things that believe that vaccines are harmful, that vaccines cause the disease they're supposed to prevent, fear of adverse reactions, side effects, co-pays. These are the numbers that are the highest. The cost of vaccines is a worry for many patients, and conflation of one vaccine with another. But the highest level is fear of vaccine adverse reactions. And I think this is something that we're seeing currently with COVID vaccine, and especially in communities of color, is real fear of adverse reactions for a new vaccine and a hesitation to get vaccinated. In communities of color, the rates of vaccination are even lower than among Caucasian populations. So what can we do as providers? Providers need to reprioritize vaccines as a normal part of primary care. Intake forms should ask patients about prior vaccination. We should screen all patients for hepatitis A, B, and C. There have been outbreaks of hepatitis A, especially around the country. All patients should be screened at least once for hepatitis C and more if they continue to be at risk. I believe in screening for measles, mumps, and rubella immunity because there are so many unvaccinated children and adults in the population these days that we may have lost the herd immunity that we had previously. If keeping vaccines is too expensive for your practice, patients can often be referred to local pharmacies and or departments of health. Some departments of health will actually supply free vaccine to practices. The CDC has some really great charts that are readily available to show vaccine schedules and what's recommended. This is one example, and you can see here with various different comorbidities, the recommendations for vaccines. Everybody gets one dose annually of flu vaccine is recommended. Tetanus is given every 10 years for all adults. If a person injures themselves and they haven't had a booster in 5 years, it's recommended that for serious injury that they get a new vaccine. Measles, mumps, and rubella, 1 to 2 doses if people are born later than 1957. Varicella for all adults except those who have severe immune deficiency. And herpes zoster vaccine is recommended. The recombinant vaccine is currently available and recommended for adults with immune deficiency, with end-stage renal disease, for heart-lung disease. Now, actually, for patients with HIV, the recombinant vaccine is perfectly safe. It is not a live vaccine and can be given to people. It is possible that if people have low CD4 counts, that they won't develop an immune response to the vaccine, but it is safe. You can see here pneumococcal vaccine, and again here in this slide, SDM is shared decision making. So we talk about these things with our patients. We recommend them strongly, but it really is up to patients in any case what they get. and you can see here the CLD is chronic liver disease. I think the rest is self-explanatory. Um, uh, Pneumonia vaccines are recommended for adults over 65 years, regardless of comorbidity, and for adults less than 65 years who have either HIV, asplenia, end-stage renal disease, heart disease, chronic liver disease, diabetes, and generally for men who have sex with men. We give the PCV13, the 13-valent pneumonia vaccine first generally, and the 23-valent pneumonia vaccine a year later. Hepatitis A vaccine and hepatitis B, all patients should be immunized for, and you can see here for meningitis some of the recommendations. So, specific recommendations for aging people living with HIV. Measles, mumps, and rubella vaccine is something we should make sure that people are up to date with. The recombinant zoster vaccine for persons greater than 50 years of age who are on antiretroviral therapy, again, especially for those with greater than 200 T cells. The pneumonia vaccines should be given to all people living with HIV, but especially those over 65, and yearly influenza vaccines. As far as COVID vaccine goes, the recommendation is that immunocompromised individuals can receive the COVID-19 vaccination if they have no contraindications to vaccination, which is generally having had allergic reactions previously to any of the components or having a reaction to the first shot. But they should be counseled that we don't really know a lot about vaccine safety and effectiveness in immunocompromised populations, and that if somebody's immunocompromised, they may not develop a full response. People living with HIV may be at increased risk for COVID-19, but it is not clear at this point. But people with stable HIV infection were included in some of the messenger RNA COVID-19 vaccine trials. Those would be the vaccines from Pfizer and Moderna and from Johnson & Johnson. There are people with HIV in those trials, but the data are very limited. Again, contraindications include a severe allergic reaction after a previous dose of COVID-19 or reaction to any of those components, or immediate allergic reaction of any severity to the previous dose. So vaccines, often we're giving multiple vaccines to people at the same time, and the CDC has clear recommendations on simultaneous vaccine administrations. It's possible to give two inactivated and one inactivated and one live together as simultaneously or at any interval. If you have two live virus vaccines, you want to have at least a month apart. The exception would be 13-valent pneumococcal pneumonia vaccine, which should be given 4 weeks before meningococcal vaccine in persons who don't have a spleen or persons who are HIV positive. Again, that 13-valent given before the 23-valent pneumonia vaccine. Again, Medicare requires a year in between them, but you can do them 8 weeks apart if rapid immunity is required. So you can see on the right some recommendations for vaccines that can be given together: measles, mumps, and rubella plus varicella plus live attenuated influenza virus, pneumonia vaccine with inactivated influenza, Tdap with inactivated influenza vaccine, hepatitis B plus MMR plus yellow fever given together, and the inactivated flu vaccine with 13-valent pneumonia vaccine. There is some caution in children under 1 based on some limited data about reactions several years ago. So what did we do with Henry P? First, he underwent testing for immunity to various illnesses. It turned out he was immune to hepatitis A, so that may have been the vaccine that he got before, but he's not immune to hepatitis B, and he showed no previous exposure to hepatitis C. His last tetanus shot, again, was many, many years ago. So he needed vaccines for Hep B, for pneumococcal pneumonia, tetanus vaccine, Tdap in this case, herpes zoster, and his yearly flu vaccine. We wanted to keep him from getting too many vaccines at once because Henry, like most of our patients, doesn't like needles. And so the first day we gave him the flu shot and the first hepatitis B vaccine Flu was the most immediate concern given the time of year. 2 weeks later, he got his first recombinant herpes zoster vaccine. 2 weeks after that, he got hepatitis B number 2 and Tdap. 2 weeks after that, the first pneumonia vaccine. 4 weeks later, so now we're at 10 weeks, he got the second herpes vaccine. So that was the 2 months after his first one. The second vaccine should be given anywhere from 2 to 6 months after the first shingles vaccine. And at 6 months, he got the third hepatitis B vaccine. At 12 months, he got his second pneumonia vaccine with the 23-valent vaccine. And at that point, he was completely vaccinated. So I want to thank you for your attention. And that's all we have today.